Hello, assalamu alaikum. So, this presentation will be a little bit of different. Instead of presentation and discussion, there will be sequential presentation and discussion. And for active participation, there will be some questions thrown out to all of you. So, as we say that who is the enemy and who is the hero, we do not know in our cath lab. So actually our patient was a 52-year-old male who had an STMI interior 3 weeks back and was only treated with low molecular weight heparin, was having ongoing angina, CCS class 3. And the ECG of that time showed ST elevation in the interior leads. Echocardiography had interval abnormalities and ejection fraction was 40%. So what do we plan to image the coronaries? So we can see that LCX is 70 to 80% at mid part, and OM1 is also diseased by 60% osteal. LAD is 100% occluded from osteoproximal part, looks to be a CTO, and retrograde flow from same-sided LCX. RCA seems to be non-critical at mid part, but distal RCA is diseased by 80 to 90%. So at this part, actually, I'm inviting Professor Dr. Fakrul Islam Khaled sir to further proceed and interact.
Thank you, Dr. Ajim. Sir, at this session, I want to question my junior colleagues. Which are you intervene now? Can you just interact?
What was the initial diagnosis? STEMI anterior.
STEMI anterior.
What was the time period between the STEMI and angiogram?
Sir, it was 3 weeks back, and patient was suffering from the angina. He was not.
So
free from
that is the
angina.
recent MI.
Recent MI,
LED
sir.
totally occluded.
LED totally occluded, sir. 3 weeks, sir. 3 weeks. Class 3 indication. Okay, sir.
Now, patient has got angina, sir.
Angina, sir.
Patient has got angina.
Got angina, sir. Repeated angina, sir. Sorry, sir. Viability, yes. Sir. So, as there is angina, I considered the patient.
So that is not actually the CTO.
Yes, sir.
LED was previously collateralized.
Yes.
There was tight lesion.
Right.
And plaque rupture produced the acute occlusion, but still the RCA giving the supply. So
Supply,
this is
sir.
the
Yes, sir. Yes,
so
sir.
this is not a
So
CTO.
we want we plan for PCI to LED. So the timing constant. So I'm going to replace, sir. We plan for PCI to
By definition, your LED is not CTO.
not CTO, sir. By
Yes.
not CTO, sir. Yes, sir. Then is it feasible for junior colleagues? Is it feasible? That is CTO. But
Yes, it's very much possible.
Yes,
Junior, for
feasible.
juniors only.
Because I just recap some theory. The LED has stamp with pencil tip, and with the retrograde flow, we can assume that the totally standard segment is small. The lesion segment is small. So we tried for LED. Then at first we put wire easily passed. So sir is right. That's not CTO.
If you want to present in this way, then you will have to tell which wire shall I tell. And first I have used the workhorse wire. You should have
What
to
was
tell
sir?
it.
This yes, sir. Sir, then wire passed easily. Just filter FCR. Just with filter FCR, not other part. Sir,
Why filter?
Sir.
That is a floppy wire. You should take a floppy wire as because 3 weeks total occlusion following acute MI, you can go easily with a floppy
filter
wire.
FC. In our cath lab, we routinely use filter FC, sir. We mostly use, sir. Filter FC, not XT.
Filter FC, I do not know our.
Yeah, actually, sir, it may happen sometimes because even it was sub occlusion with stable plaque, subsequently total occlusion. Initial plan should be workhorse with microcatheter
That's right,
help.
that's
So
right, with
if it fails, then second any of the
Yes.
Can be.
that
Okay,
is
sir.
Second line
polymer jacket or you can use.
And Professor, you have told that your workhorse wire is a filter FC wire.
No. Filter any polymer jacket should not be as a workhorse.
He is telling like
No,
that.
that is not.
Sir, that after ballooning with 1.5 into 12 size, with repeated ballooning, There is no reflow. You can see the no reflow is there. There is no reflow is there. No reflow with ballooning. No reflow
Yes,
is there.
that can happen.
Then no reflow. Then what is called the no reflow? Here is my question. No reflow. Is there wiring false stack or dissection of thrombus or spasm?
Most likely thrombus.
Thrombus. But and
Give,
so
give GTN, then
then
first of all you have given GTN.
yes, nitrate and I have the nitrate and
Adenosine.
adenosine.
then
Yes, sir.
adenosine.
No,
Then you can also.
not corrected. Not corrected. Weighted but not corrected.
How much
First of all,
balloon?
don't lose your wire. Keep that wire in.
Wire is inside.
yeah,
Wire is inside.
rewiring,
Not rewiring.
yeah.
Wire is inside.
You keep here
Because
projection,
branches
you
are
have-
all branches, septal and diagonal branches are seen. So I was in lumen, not false track. The septal and diagonal branches in. So the balloon was easily passing, easily dottering, but no reflow. Balloon dottering was easily dottering was done. Then I just hemodynamic stable. I deferred the case and I put on heparin, low mode heparin. After 3 days, 7 hours, then again recheck this. Similar findings. After that, similar findings. Then wire and balloon.
Just if you go back to the previous first slide, collateral from the right,
Yes, sir.
you are there is dissection in the proximal LAD. There was dissection. Probably that was the region.
No.
First slide. Collateral from the right. How much? Yes. No. Collateral from the right. Just RCA. Right. RCA. RCA? Yes. Cranial?
Collateral from same side, sir.
No.
Not RCA.
2 minutes. Because another IVAS workshop is going on, so you should hurry because EMAS is there. Okay, 2 minutes.
So there was elastic recoil of the proximal atherosclerotic segment. And when I put the stand there, the whole system is then visualized. And then within these 2 days, I studied that, what is the cause. Then I put a stand in the proximal segment, standard segment. Next. They all visualized. Then next. This is the cause, sir. Elastic recoil of the atherosclerotic segment. This is the, yeah. I repeated. I did repeatedly from point to point. Okay.
And
Long balloon.
Dr. Tan, hello, Dr. Tan. To me, to deploy one stent, I must have to evaluate the distal flow. What is your opinion?
So when you have poor flow in the STEMI situations like this, you don't know whether it's the proximal part that is obstructing or whether it is a no reflow phenomenon from extensive myocardial dysfunction. One of the things that you can do is actually put a microcatheter deep down, give some vasodilator and take a shot. If there's no runoff, this is a no reflow, nothing you can do. But if there's runoff, then it's a proximal occlusion, then you have to deal with it with a larger balloon and stent.
Actually, also intravascular imaging can help in understanding what's going on as well.
Thank you, sir. Okay. you should think about electric recoil of this segment. And another thing, I think that, IBUS would help us, but we have sent no IBUS at center. Thank you, sir.
What I say, this is the main message.
Thank you so much. I think they are an excellent presentation. Dr. Imas Sivan and Tane Chim. Just, it's very much tough for the young colleagues, like a expert panelist, Just.